Okay, so I think it's showtime. So good afternoon, everyone, and welcome. Thank you for joining us today for the National Hispanic Medical Association Mental Wellness in HIV case and the roundtable. My name is Dr. Colon-Rivera, Dr. Hector, and I'm the medical director for Asociación Puertorriqueños en Marcha. Also work for University of Pittsburgh as a physician, and I'm the member of Crear con Salud, a nonprofit in Puerto Rico. I will be serving as your moderator today in today's event. And just a little bit about National Hispanic Medical Association, which is a nonprofit association representing the interests of nearly 50,000 licensed Hispanic physicians across the United States. The NHMA mission is to empower Hispanic physicians to lead efforts to improve the health of Hispanics and underserved populations. The National Hispanic Medical Association has partnered with the Center for Disease Control and Prevention, the Let's Stop HIV Together campaign, to disseminate culturally appropriated HIV resources to the Hispanic community. Today, we're joined by CDC Clinical Advisor, Dr. Sara, Associate Professor in the Division of Infectious Diseases in the University of Nebraska Medical Center, along with the CDC Community Ambassador and Outcare Health Representative Asia Sullivan, a physician assistant and primary care provider in Los Angeles, California, with a focus on LGBTQ plus health. We also have Dr. Karinn Glover, board certified psychiatrist and the director of adult behavioral health at Montefiore, and an assistant professor of psychiatry at Albert Einstein College of Medicine, to have an instructive conversation about the connections between mental health and HIV prevention and treatment within our communities in recognition of January observing Mental Wellness Month. Celebrating mental wellness means honoring your mental health by bringing awareness to the topic and participating in activities that promote overall well-being. For us today, this includes emphasizing the importance of routine HIV testing, the status awareness, and continued focus on making HIV prevention and treatment effort a priority. But what happens when you do not know where to start or how to ask the right questions when HIV stigma prevents you from doing so? This webinar and roundtable discussion with the field experts you will have the opportunity of answering these questions you have on the on the link between mental health and HIV care. Everyone who is watching live today, we ask if you have any question to please drop them in the Q&A box, and we will incorporate them into our discussion, or send a follow-up fact sheet with resources to accompany the response that we have. So with that, we hope that our conversation today can provide visibility to clinicians in the HIV work, also to members of our communities, and how their patients experience mental health challenges and stigma connected to LGBTQ plus health. We aim to highlight the importance of mental health, mental wellness, and tailor it to HIV prevention and treatment services among members of our communities. Also, by doing this, we provide clinical communication tactics to address stigma barriers. With that being said, I welcome you all to our esteemed speakers to our discussion as well. So I know when I deal with this situation, I mean, the first thing that comes to mind is diagnosis. And I want to ask the panelists, I mean, what guidance and communication options will you recommend when addressing a patient that is the first time meeting about their diagnosis of HIV? I'm going to start with Dr. Sara Barres.
Yeah, sure. I'm happy to start with that question, and just welcome to everyone who's participating, and thanks for the opportunity to participate in the panel. I am an HIV provider, and so this is something that I do on a pretty frequent basis, and everyone has different styles, but I think one of the things I've learned over time is that the most important thing when walking into the room is to first really start with on a positive note, because so often the patient in the room is scared for a whole number of reasons, you know, and every patient's reaction to a diagnosis is different, but to really start with a positive note. And so you know that a million things are going through their mind. And so I start by walking into the room and saying, welcome to our clinic, welcome to our family. And what I want you to remember from this visit, if you remember nothing else, is that you can live a long, healthy life with HIV. I think just starting off and reminding them that we have data to support that the life expectancy in people with HIV is approximating that of people without HIV. And again, if from that point on, they don't remember anything that you teach them, anything that you go over, at least you've started with that. And then the next most important thing is to really get a sense of what they know and what their fears are, again, because everybody is different. I've had patients who are, the only thing they know about HIV is that their uncle or their grandfather died of HIV in the 90s, perhaps. Whereas I've had other patients who worked for years as community health educators and have much more knowledge about HIV than most of my patients. And so to really start by understanding where they're coming from helps me know what language I can use, how specific I need to be, how much I need to break down some of the basics, and then I can go from there.
Asia, what about you?
I agree with everything that my colleague said. I think that starting the conversation first in a positive way is of the utmost importance, and reassuring the patient that you didn't do anything wrong. In fact, you did everything right by being tested, by knowing your status, by taking that next step to come in. The people should be really commended for that, because that's one of the big issues here in the US, is that so many people living with HIV are unaware of it. And so that's, the most important thing to do is to know the status. And yeah, exactly, that they will live a long, healthy life there. They can have children, they can have normal sex lives, and all of that. So, to just reassure patients that they did not do anything wrong, they are not dirty, that idea of kind of dirty, clean, positive, negative, that this is something that they will live with, and that they will be just fine, likely take one pill a day, or sometimes even a long-acting injection, and just be able to live a normal, healthy, happy life. So I 100% agree.
Yeah, and I know Dr. Clover, I mean, usually you don't see the patient for the first time when they're and break the news like that, but they probably follow with you, right, Dr. Clover?
Yeah, thank you. So I'm Karinn Glover, psychiatrist, and I am not director of behavioral health at Montefiore, at Cityblock, which is a Google spinoff at this point. So just want to update the audience in case they're Googling, because there's some leftover web pages at Montefiore. And as you can imagine, a big institution doesn't change things sometimes for years. So, So I worked in an integrated program. So people were being seen in primary care, and I was the psychiatrist in primary care, and I still do that. And that's been essentially almost 15 years now. And one of the things that came up repeatedly in clinical settings for me in the South Bronx, which is one of the lowest income congressional districts in the United States, is that when people are diagnosed, we have to ask about safety. Often people are in relationships because they are having sex for safety, sex for food. So there's sometimes sex work involved in contracting HIV. And so gauging safety, helping people process their anger, helping people who have been trafficked, all of those things are also part of the conversation, helping people come to terms with their sexuality, because sometimes they were contracting the virus while they were under the influence of substances. And we just started to have a realization that HIV for them was maybe the starting point for examining their lives, and for perhaps making some changes that involve less substances and more healthy behaviors.
Wow.
Without judgment.
Without judgment, yes. And talking about judgment, right? The stigma is always there. I mean, we have been treating, HIV for what now, almost 40, almost 50, 40 years, right? More than 40 years. But we still deal with a stigma. So how can understanding the importance and impact of HIV stigma allow providers to be more aware, right? And we're talking about our colleagues, right? How do we educate our colleagues to measure or to assess their own bias sometimes? And how do we deal with that stigma with our patients? Ms. Sullivan, you want to start?
Yes, I think that is one of the biggest battles in medicine, or HIV medicine, both for clinicians and for patients, is overcoming the stigma and the misinformation surrounding HIV and the diagnosis. In terms of our fellow colleagues, I always mention the strategy of like a status neutral approach to testing, in which if you are a provider, regardless of if you are dealing with HIV regularly, just in your general family care, maybe even dermatology, gastroenterology, whatever specialty you may practice in, there's always the opportunity to bring up HIV testing and just offer testing to anyone regardless of what you perceive their risk to be, because oftentimes the only people who are offered HIV testing are gay or bisexual men, often gay or bisexual white men, and a lot of times women and people of color and trans folks are left out of that conversation and not even offered the opportunity to be tested because their perceived risk is low in the minds of clinicians. But we know that actually these marginalized groups are actually at the highest risk for HIV. And so I usually encourage providers and other clinicians to just bring that conversation in a very neutral way. Hey, by the way, when was your last HIV test? Do you know your status? And then to be prepared. So if you have a positive result, be able to link that person to care immediately so that they can start treatment ideally immediately. And if that person tests negative, great, let's talk about PrEP or connect you to a PrEP provider, so that either way, you're offering it to everybody, from the, married lady with 4 kids to the grandma to the, gay teenager. So just making that an option for everybody, regardless of what you perceive their risk to be, and talking about it in just a very neutral and relaxed way.
Dr. Barris?
Yeah, I can just piggyback on that. I actually wanted to piggyback on what Asia started with earlier, which is how important it is to remind patients that they did nothing wrong. I think that can't be overstated. Even if we're not thinking that, we don't think that about our patients. We all went into the field of HIV care because we know that there are so many external factors that impact our patients. But even if we don't explicitly say that, understanding that our patients are hearing that in so many ways from society, whether it be from their church because their church group disapproves of, their choice in their sexuality, or whether they're so many external factors that they internalize that stigma. And if we don't explicitly tell them that they've done nothing wrong, they may continue to believe that. And so I would just wanted to start with that, and that will also help to remove the stigma. I think in terms of being aware of our own stigmas, I think that's really important too, and understanding how that might affect care. And so everything that Asia mentioned, that status neutral approach, and educating all of our peers and all of our providers. I've worked really hard too to educate our providers who many of them went to medical school many years ago and don't know data such as undetectable equals untransmissible, and trying to really share that with other providers so that then they can continue to communicate that message to our patients, because it always astounds me how, even though I think that message has reached all of my patients at this point, it really hasn't. And they need to hear it from multiple providers in different specialties before they really begin to believe it. And then I think also just as a full clinic, training in safe space training, so that everything that every interaction we have with a patient is positive and without stigma. You know, I think that's something we're continuing to work towards, and our clinic is far from perfect, even though we've all done safe space training, but remembering everything from asking patients about their pronouns and asking, and, you know, removing gender from the bathrooms, every little thing that we can do to make patients feel safe and to realize that we have stigmas that may be unrecognized is important.
Can I add also, I try to pay very close attention to the language my patients are using around how they contracted the virus. So I've had a lot of patients say, cuando yo me metí en vicio, right? And I'm like, hey, wait a minute, you know, like this, you can look at it the way you want to, but like, if we're looking in terms of like, to have vices, right? Or to have sinned as a way of contracting the virus, I'm like, look, I don't look at it like that. I look at you as being a human, and you did what humans do, especially when we start to talk about their history, their trauma, stuff like that. I really try to normalize for people, like, I don't use that. I don't use those words, and I'll tell you why.
I agree with all that. And of course, I mean, when we talk about stigma, it's not only the stigma that society can have, right? We need to measure our own, but also family members can bring a lot of stigma. So educating family members and anyone that's surrounding that patient is really important. And partners, right? Having the partners also include the partners on the conversation. So we know HIV usually does not come alone. I mean, our patients can suffer from other comorbidities, and that includes mental illness, mental health. And I wonder, I mean, how do we deal with people showing signs of mental illness? And I want to start with, of course, Dr. Glover. I mean, this is your area of expertise. How do we link or educate people about mental illness that also have HIV?
Myself. Okay. So, you know, one of the first things that I tell my patients is I have people in my family who have HIV, and I want to make sure that you get treated the way that I would want a family member to be treated, the way that I want my family members to be treated. So it can involve, I think for me, it involves a full assessment. So I work in a place where even before the patients come to me, they are screened, everybody, regardless of their status, they are screened for mental disorders like depression, anxiety, trauma, substance use. And from there, by the time they get to me, I'm already kind of informed about some of the challenges, but obviously I want to hear from them what their life has been like, and I want to hear their own personal narrative. And of course, not everybody is able to put that together. So we work together to construct a sense of their life and how we can be helpful going forward. I also understand that up to 60% of folks with HIV had a pre-existing mental disorder before they contracted the virus. So there's usually my patients are aware of a diagnosis. They may have been hospitalized, or they may have had very severe trauma. Many of my patients have been trafficked sexually in other countries before they got to the Bronx. And so some of that has to be talked about, because I need to know if they're still being exploited, or if they are still just having sex for money and they're not being exploited, but also sort of how they are making a living. So in addition to that, I need to find out the impact of their mental disorders on essentially their health behaviors. And usually it means, I mean, the good part is that the patients come see me in primary care. So they're not going to necessarily a special clinic only for people with HIV. They're fully integrated into primary care. Nobody knows about their diagnosis when they walk into our building. And they get to just see me as like the lady down the hall, right? The lady down the hall who likes nice shoes. to be clear. So we get to talk about lots of things. And so I think in many ways it sort of normalizes not only getting mental help, but also getting their HIV care all in one place and in a place that is not designated for either necessarily. And then I think I also try to have very honest conversations with my patients about not only controlling the virus and being undetectable, but also being aware of the ways that HIV can affect their mood, like literally because it lives in the nervous system, how it can affect their mood, their sleep, and their cognitive speed. And so once I start breaking some of that stuff down for them, in many ways, it's kind of a relief, because some of them have said, like, I'm so tired and I just feel like I'm in a mental fog. And right, then we have to start thinking through, like, what was the lowest your CD4 count ever was? And what was, you know, we call that the nadir. And if I know that HIV has been living in your central nervous system and you have for 30 years, then we need to make sure we keep on keeping track of your any kind of neurocognitive decline, right? And so I also need to make sure and pay special attention to sleep, especially for my patients who have a history of a bipolar disorder and history of mania, and who are also just trying to function. And so that means we have lots of conversations about quality of life, that things that we think are quality of life, but are actually crucial, not only for mental health, but also for general health. I'll pause there.
Sullivan?
Yeah, I think that Dr. Glover did a really great job addressing that specific question. The only thing I would say maybe that that I thought of as well is, you know, the diagnosis alone can have significant impacts on patients' mental health. And I think, you know, understanding that kind of goes back to what we were talking about earlier, trying to reinforce to the patients that this is nothing that you did wrong. It was not a sin to contract a virus. And also, I think that patients do much better from a mental health perspective when they are also educated about you know, the things that they can do to be in control of this, you know, to maintain that undetectable status, to understand that you know, with an undetectable status, you will not transmit this virus to anyone. You don't have to. That's one less thing for you to worry about. You know, making sure they understand that if your CD4 T cells are at a certain range, you're not at higher risk for different infections. You know, what you have seen portrayed in a lot of media regarding HIV is not the reality of HIV the way it is today. So I think there's a lot of power in understanding those things for themselves, and that alone can also help improve, you know, just kind of the overall mental health of the patient as it relates to their HIV diagnosis.
Yeah, I think those are all really fabulous answers. And again, I'm learning from my colleagues here. The other thing that I would add is that there is still a lot of stigma surrounding mental health diagnoses and mental health symptoms. And so just reiterating how important it is to screen for those symptoms, because patients may not come forward with them. They may not present with a mental health concern or complaint. And so we have to really ask routinely in our review of systems about mental health symptoms so that we can then address them. And again, just like you guys said, destigmatize, remind patients that the HIV may have impact on the mental health and vice versa. And so they're all interrelated. And, you know, I even tell patients, actually, COVID really helped destigmatize mental health because it was more on you. I said, I would be concerned if you weren't impacted, if you didn't feel sad or depressed or lonely or, you know, from the isolation or from the COVID or from all these, and that really removed some of the stigma of just seeking mental health services. And so I try to do that in other ways too. It would be unusual for you not to have some symptoms. I'd be more worried about you if you weren't having any concerns at this point. And so really, in order to give patients really the permission to share those symptoms and to seek referrals when possible.
That's great. That's great. So what are the, I mean, techniques or resources that we can teach or, you know, have for our communities, Hispanic communities? I mean, is there any resources out there for people suffering from HIV and mental illness? And what are those resources? I mean, what you guys use in their practice for people suffering from both disorders, diseases?
So for me, we try to do as much at our clinic as possible, and we have been really lucky. We had a psychologist who was very rooted in the community. So we know that a lot of our patients come from Puerto Rico and Mexico and the Bronx. So we made use of community gardens. So sometimes, you know, for the patients we had a women's group for women with HIV, and we would go to the garden to have our talks. And that was a space that felt, that reminded them sometimes of much better, happier times when, in the spirit of being in nature and in a very, very urban place that doesn't have a lot of green space. And we know that green space has been known to boost mood and help people breathe healthier air. So we would have our women's group in the community gardens in the South Bronx. And we would also, in many ways, try to leverage the community wisdom and the cultural wisdom. So for our patients who were maybe into the culture and the religion of Ifa, then we would say, you know, maybe there were times when I was like, you know what, as your psychiatrist, I only know so much. Would you want to talk to your Babalao? And I'm happy to speak with them too. And maybe we can work together to help you, because if this feels like a spiritual crisis to you, then I want to work with the spiritual expert. And that I am not. So I really tried to normalize for people, like, not only have I know enough about what we have in common as people of African descent, but also I'm going to leverage what I know and read and spend my free time learning about, so that you know that I see you. Right. And so I used to live in Mexico. So for my patients who come from Mexico, it's all about what part of the country do you come from? What, you know, if you have indigenous background, what are some of the beliefs that you came here with? And how can I help leverage some of those? Do you want to talk to your pastor or your religious leader in the church if you're Catholic? And to what extent do we need to work with that person to help you feel better about what's happening? So I think just using and leveraging the religious history, the spiritual history, understanding some of the structural factors that led to and affect their lives on a daily basis, whether it's housing, whether it's their access to care and all those things, just and understanding the history of where they came from, and maybe if they migrated to the Bronx, why and when and how and what that was like for them. I try to involve all that into any discussion about mental health and HIV.
Yeah, I love that approach. I would say I think more of it as not as providing mental health sort of integrated and throughout the whole in an interdisciplinary fashion. And so one approach that we have is at every initial visit with our patient, we tell them to plan to be there for hours, because our very first visit, we do a really, really thorough history and a trauma-informed care approach where we really try to backtrack and have them tell us their life story, so that can then, we're not just getting that story later when they have a crisis and to understand how that's impacting them, but so that we can really know from the beginning where our patient is coming from, what their where they seek support. All of those things are really, really important. And then another thing I would add is that we've really encouraged all of our providers, even if we're not, special, even if we don't have specialization in psychiatry or other services, to really become adept at sort of the basics of mental health care, so that we can not have to rely on our experts for every single patient who is experiencing depression or other mood disorders, so that we can begin to offer some treatments and then reserve our specialists, because I practice here in Omaha, Nebraska, and we have a shortage of mental health providers. And so our patients will often have to wait months to years to get into a mental health provider. And so if we can at least begin to offer some of the more less complicated mental health care, then we can reserve our specialists for the ones who really need more advanced, higher level expert care. Yeah, so we try to integrate it throughout, I would say.
Yeah, I agree with those things, especially, even here, I'm in Los Angeles, and you would think that, psychiatrists and mental health care would be readily available in such a large city, but it's really not. We have the same experience with our patients having to wait months to see a psychiatrist. Many psychiatrists do not accept insurance, do not accept Medi-Cal, Medicaid, those sorts of things. And so I agree with that in terms of trying, being able to sort of offer baseline, first line therapies for mental health and have those discussions. In terms of resources for patients, I usually encourage patients to seek out groups of folks, like Dr. Glover was saying, people who are within their same communities, whether that's, their religious community or racial community, or, whatever it is that they identify with, because typically those groups are out there, and it's always helpful to have peers who look like you, who know where you've come from, who have those similar shared experiences to kind of give you a support system, and also for you, if you are living with HIV, to see that there are others, within your community who are thriving, doing well, living their best lives, and that can be you too. I also encourage patients and people who do not live in, New York and LA and San Francisco, where those groups are readily available, to utilize the internet. There's a lot of great resources online, peer groups for just about any condition and any group of people you can think of. Outcare Health is a great resource. The CDC actually is a great resource, and I can provide those specific links later in case anyone is interested. And also in terms of resources, with the COVID pandemic, we saw a explosion of telehealth services. And so if you do live in a rural community, or there's not great access to culturally competent, informed, like queer-friendly providers and that kind of thing, don't settle for less. Don't settle for providers who make you feel bad about yourself and your condition. I always encourage people to go online, utilize telehealth, and connect with a mental health provider, a primary care, anything that you may be seeking, you can typically find online if you can't find it within your own community. And like I said, I'm happy to give those specific links maybe later in case anyone's interested.
Yeah, that would be
Also, if it's okay, I also add that that there are some really good magazines and online resources. Like, I always liked Pause for patients, right? Because there's always inspiring stories. So I always try to connect people with stuff like that as well.
Thank you. Yeah. Yeah, we received some of those in our offices, and we provide the magazines. They're pretty good. Actually, they're really good. It's a good writing. And thank you for sharing that. And I'm pretty sure that CDC have resources both in English and Spanish, right? That we can use for our communities. There's a question in the chat that I will read. It's related to people living with HIV to donate life to others with HIV. And why is that HIV medical providers do not know or share this knowledge? Anyone want to answer that?
I think in that specific regard of organ donation and kidney and organ transplants, it's probably something that, especially if you are kind of within our realm of like primary care, it's not something that comes to the forefront of our practice very often. But I think it's important to know, so it's one of those things that can probably help reduce stigma, because that's such a huge thing, you know, like it speaks to how folks who are living with HIV can maintain that normal life. It's within the same thread of, you know, you can have a baby, you can, you know, get married, you can have a sex life, you can do this, you can do that, you can even donate your kidney if the time ever came. And so, you know, while it's not something that I think it's kind of a highly specialized area, and that's probably why most just your average sort of provider is unaware. But it is one of those things that I think people should kind of know about as it relates to the conversation of like, look, you can have this normal life, both socially and medically, and even donate a kidney should you need to one day. And I think that's a good topic to kind of add to the list of things that you can still do just like anyone else. So thanks for bringing that up. That's really incredible.
Yeah, and I would say thank you for bringing that up. And I think the reverse is also true, that our patients can also receive organ transplants if they need them. You know, so for our patients who are advancing in age or have underlying kidney disease or other complications, we do make sure to let them know that, or connect them to our transplant program if they are a candidate. And so I think it's great that you brought that up. It is really something really that's important.
Can I also offer with regard to transplantation? I have had patients who came to us in addiction and developed hepatitis and developed renal failure, and their health was in really, really dire straits, who got transplants. They were like, as soon as they found out they could be on a transplant list, they were at every meeting, took all the notes, put down the crack. And I'm like, what? I mean, we were all like, who stops using crack? Like, how does that even? And one thing I had to learn is that when people are motivated, they are motivated. So my job is to support, and let's get you that kidney. Let's get you that new liver. And so I have a patient who not only got a new kidney, he got a new liver. And when I tell you this, he bought a new car, he got a new life. And I mean, what a transformation. So I really try to make sure my patients know that things that you can't even imagine are possible, and let them happen. And we're here to support.
That's a great question. That was a great question. So I'm going to open the microphone, right, the space for anyone in the audience to have any questions for the panelists today. Don't be shy.
I can just start with the question for my co-panelists, maybe, while we're getting something from the audience. I think one of the things that we didn't really touch on that we struggle with a lot is a stigma that's really particular to our Latino community, which is a lot of my patients are immigrants and aren't documented. And so really fear disclosure of not only of their HIV status, but of that, you know, if we apply for Brian White or other federal support programs, that then they may be asked to leave the country, deported, or, you know, they have so many concerns. And for that reason, that same concern means that a lot of times they'll use different names, or, you know, we won't be able to have immunization records, or they'll have been diagnosed in another state and even received antiretroviral therapy somewhere else. And then we don't know that because, again, they're using different names. And so one of the things that we do is we try to bring that up front without them asking, and really assure them that their immigration status will not be disclosed, that it may impact their eligibility for federal insurance or something, but certainly not support programs or grant services or other programs. But they're wondering how you, since both of you probably work with a large immigrant population as well, sort of what some of the ways that what are some of the things you do to help address this head on and really relieve patients' fears and concerns?
So in New York, they've dedicated, they being like the Department of Health and whoever the mini gods are who work with CMS, make sure that there is adequate funding, not only for documented people, but undocumented people with HIV. So people get their medications for free, their HIV meds for free. When it comes to their psych meds, that can be a little more prickly. I've definitely had people concerned about that. The good part is that FQHCs, federally qualified health centers, usually are funded well enough to offer a sliding scale and to assist with getting low-cost medications. Also, that means I, as a prescriber, need to know the cost of the medication. I use GoodRx a lot to help figure out where some of my patients can pick up their medications for as low cost as possible. So I think a lot about that. And then also I need to think about what it means for their housing, like whether they've got stable housing, if they're undocumented and they're renting a room or something like that. What does it mean for their economics, right? And financial stability to now have to afford whatever sliding scale medication costs there are. And again, the good part about going to an FQHC that is, generally a learning, a site for residency training, is that they're going to see people who are highly motivated. They're going to be supervised and precepted by folks who have been doing this a long time. But I do have to let them know, there are some of those dynamics as well. Like, you're going to be treated by somebody who's in training. And were we living in an incredibly just and equitable society, you would get to see the expert of your choice for as long as you want and need, right? So those are some of the conversations I've been having with my folks who are undocumented.
Yeah, that's all really good points, and a great question to bring up as well. Here in the LA area, we do deal with this specific situation quite often. And in addition to the things that you all mentioned, I always like to remind patients, even without having to be asked, of HIPAA and the laws surrounding their personal health information. And I remind them that healthcare providers are not required or encouraged to report your immigration status to anyone, and everything that you discuss with us here today is literally protected by law. It is like your right to privacy. I cannot share that with anyone, nor would I. No one in our clinic can. And so I think that is something that can bring people a little bit of peace of mind. And then in terms of access, there are many different programs here in California. I think nationally, the ADAP covers folks for, to get treatment, to get medications, to get labs, and that has nothing, those programs have nothing to do with your immigration status. And there are also many, many clinics, the AIDS Healthcare Foundation here in LA, APLA, lots of different organizations that will help you get on PrEP or on treatment, regardless of your insurance status, immigration status, financial status. And so I always like to remind patients that it is literally their right to privacy when it comes to their health care.
Can I also add that asylum seekers often need our help, and I see you all nodding. So I'm guessing that this is not unfamiliar, right? And so I've had to learn how to work with the immigration lawyers to write the right kind of letter to advocate for the patient. And I've also had to educate myself on what's happening in their country of origin. And I've had folks from different places in Nicaragua, El Salvador, and Belize who were like, you know, look, when my status became public, I can't live there anymore. It's so deeply stigmatized. I won't be able to get a job. There are people who would threaten my family if I go back. My family won't take me back. And so I've had to educate myself on some of those factors as well, and be able to write a really good letter.
Thank you. Those are great answers.
That's great. That's great. So it requires a team, right, for those cases. I mean, and being familiar with the laws, local, federals, and the situation of the family. Wow. There's a question about stigma, and so this I'm going to read the chat. The stigma and duration of illness among HIV patients were found to have correlated with the risk of developing a common mental disorder. HIV patients who had perceived stigma were 5 times more likely to have a common mental disorder. Is this true? Is it a fact or not?
So I don't know those particular statistics. I do know that a very large percentage, over 50% of folks who are diagnosed with the virus have a pre-existing mental health diagnosis or condition. And so I think the diagnosing HIV and also screening for mental health disorders go hand in hand. And I think that is best practice around the United States at this point.
Yeah, I would agree. I'm not familiar with that exact data or where that where that came from, but absolutely very likely to be true, or at least based on solid evidence. And I would just highlight that I've learned a lot from my patients over the years, and from community representatives to our research trials, and just a reminder to everyone that the language that we use is really important. And so if we can try to focus on patient first language, and it's really patients with HIV, they're patients first. I know there's still a lot of old data out there, including data of my own that I cringe at, that says HIV patients, but the more we really put the patient first, the better we're gonna, the more likely we are gonna be to reduce stigma and empower our patients.
That's great. Thank you for that. There's another question. How can healthcare providers implement trauma-informed care in HIV care to better address the mental health needs of underserved communities? For example, new immigrants. So trauma-informed care.
So I'll start, but I know Dr. Bears has lots to offer with regard to that as well. And I'm sure Ms. Sullivan does too. I know at my institutions, everywhere that I've worked, there is a trauma-informed care component or training module that has to be done every year. And when people first start and join our institution. So I think, it's everywhere now, thankfully, everywhere that I've worked. I'm not sure about other places, but I think if the healthcare systems are in neighborhoods that are typically underserved, if the population mostly consists of folk who have been marginalized and have been on the receiving end of lots of societal violence, in order to be structurally competent and in order to make sure you get the health outcomes that you need, trauma-informed care is key.
Absolutely. This is a great question. I always try to think about or focus on not re-traumatizing a patient as they come in to seek healthcare services, because I believe, you know, all of us have had a negative experience with the healthcare system at least once, and many folks who are, you know, already marginalized, whether that's due to immigration status or sexual orientation or gender identity or whatever it may be, probably have many more negative experiences that they can recall. And so that is one reason why we know for a fact that people don't seek care, because once they do, they are, you know, they experience either shame or you know, just you know, maybe they're misgendered, or maybe they are made to feel that this is their fault. And so I try to make sure that we do not accidentally re-traumatize someone, to make sure that we can try and change the experience that they have, because sometimes that's all it takes, is just one positive experience with a healthcare provider to kind of change the outlook on health and to keep people coming back, to follow up with your recommendations. You know, people are not going to take medication prescribed from someone that they don't trust, that they don't connect with, that they don't feel truly understands them and has their best interests at heart. And so I try and be aware, our clinic tries to be aware of all the different barriers to health. It's not just making an appointment and being prescribed the medication. There's so many other things. Do you have reliable transportation? Can you afford this medication that we prescribe? You know, I've even experienced where patients don't want to tell you that they never started the medication at all. You know, you prescribe them something, you think everything's going great, and then come to find out they never started it and didn't feel comfortable enough to tell you why. And so I think when we kind of start from that perspective, as it relates to trauma-informed care and making sure that we are not being the, you know, perpetrator of the trauma, is of the utmost importance.
And I would add, I love those answers. I would add that the way what I've kind of seen to understand is trauma-informed care is to not ask whether or not a patient has experienced trauma, but to ask what that trauma has been, or what those traumas have been. Is our approach, is, you know, understanding that most patients have experienced trauma at some point in their life. And so I saw a question in the Q&A too about, you know, what about mental health care before, mental health referral before even the biomedical visit. And one of the approaches that we've done is we've really worked to coordinate with our intake and case managers. And, you know, even if the provider doesn't have a visit for a new HIV diagnosis for a week or so, oftentimes we can get a patient in with a case manager the next day or the same day as the diagnosis. And then that's where we take the really full social history and really the history of all the traumas, so that then we can, you know, hopefully work hard to do all the things that you are reminding us of, which is avoiding re-traumatizing the patient by understanding what their past traumas have been and what they're bringing into the visit.
Oh,
Can I add a little something more?
a little
I know we're
something.
at time. Okay, I'll make it. It's gonna be really little. When Dr. Bears mentioned case management, any of these ancillary folks, and I hesitate to call them ancillary because they are so crucial, but just anytime we have care managers and case managers, anytime we get to work together as a group, it gives us each the opportunity to share more information about the patient. I find that often it's very hard for people to tell their complete story in an integrated way that healthcare providers can easily wrap their minds around, right? People have had very complicated lives, so they have complicated ways of telling us who they are and what they need. So one of the best things is to leverage the really crucial folks in case management, especially if they're willing to go to the patient's home, if that's part of their job and they're covered for that. Amazing.
And especially because we can diversify our group that way. You know, we only have a certain number of male providers or female providers or Latino providers or Spanish speaking providers or Black providers. And I think our case managers, you know, hopefully will have a better chance of at least matching our cultural competence, or our, you know, having somebody who looks like the patient, who or understands the patient or comes from a similar background.
And we need to treat this as a team, right? I mean, different backgrounds, peer support groups, peer support. I mean, case managers, social workers, nurses. I mean, all of them are part of the team, including family members as well. So our time is over. So I just want to thank you guys. I mean, firstly, I would like to thank you, our guest speakers, for their time and expertise on today's topic, as well as our live audience for participating today. Great question from the audience. A recording of today's discussion will be added onto the National Hispanic Medical Association YouTube page and webpage within a week. So wait for that. Please keep in mind that resources on HIV prevention, treatment, and care are available for both physicians and patients in the hispanichealth.info website, as well as the CDC HIV Nexus webpage. We hope that everyone enjoyed our informative conversation. Please join us for our upcoming events. And if you have any questions regarding our HIV program, please reach out to our program manager, Jason Hernandez, and the email is on the slides. Thank you all again and enjoy the rest of your day. Thank you for joining us.